Welcome everyone. My name is Kathy Crawford. I have been an ICU nurse for 29 years. I've worked in a variety of ICUs and I've had different roles throughout the course of my career. I currently work in a medical ICU. The hospital I currently work in is a large teaching hospital. We're a level 1 trauma center with over 1,000 beds. The medical ICU I work in is a 22-bed medical ICU. And out of that, we also have our rapid response team and what we call the MICU alert nurse. We actually go down to the emergency room to take care of our ICU admissions before they come up. So I have an opportunity to use hemodynamics in a variety of settings, and that's what I'm going to be discussing today. My disclosure is I am a paid consultant for Edwards Life Sciences. The objectives we're going to talk about today, we're going to focus on using hemodynamic monitoring parameters, specifically stroke volume, to guide care in the hemodynamically unstable patient. I'm going to spend a lot of time talking about hypotension because I do see that a lot in my practice. And you're going to be able to utilize the principles of hemodynamics in addition to vital signs to treat these unstable patients. Well, we're going to start with vital signs. I think a lot of us, if we look at these vital signs, I included these because these are relatively normal vital signs. And I really want to focus and talk about the mean arterial pressure, because I think a lot of times, especially in critical care and even down in the emergency department, we do focus on the mean arterial pressure. And our goal the gold standard now is to keep the MAP greater than 65. And we have this idea that if our patient's mean arterial pressure is greater than 65, that they're in fact stable. And that they're not only stable, but that we're able to perfuse, that they have good tissue perfusion. And I want you to think not just about blood flow, but about tissue perfusion and how well we're oxygenating our liver, our kidneys, our fingers, and our toes. When we talk about traditional measures, specifically the mean arterial pressure, I want to talk about how it is slow to respond, and it doesn't always tell the full story. I honestly, if you give me a patient, I can make anyone's mean arterial pressure greater than 65, especially if I start adding medications such as norepinephrine and neosynephrine. But patients that are on medications like that, or patients that are severely vasoconstricted, do they really have good tissue perfusion? And I love this quote that I found from Garcia and Gonzalez. A normal arterial blood pressure does not necessarily discard the absence of hypoperfusion. Because you have to remember, our bodies are made to sustain a mean arterial pressure greater than 60 or 65 at all costs. And we will vasoconstrict in early signs of shock states. And I think we want to start moving away from thinking about the mean arterial pressure and assuming that just because you have good blood pressure, that you have good blood flow and good tissue perfusion. So hemodynamic parameters, why do they matter? We're going to talk about stroke volume, systemic vascular resistance, cardiac index, and cardiac output. We're going to talk about how you can use these parameters in addition to the mean arterial pressure to help guide care of your hemodynamically unstable patient and maybe the patient that appears to be stable but has some things happening that we can't quite see. I want to take a little bit of a step back and do a little hemodynamics 101. I want to talk about cardiac output. Cardiac output is the amount of blood that is pumped by the heart, and it's used liters. The measurement is liters per minute. So how much blood is your heart pumping over a minute's time? And a normal cardiac output is 4 to 8. And it really does depend on the patient's height and weight. So when we look at cardiac output and we have that big variability, we can actually do an index, cardiac index. And that, when you index a parameter, you're taking into account the height and the weight. So a cardiac output is divided by the body surface area is your cardiac index. Stroke volume. Stroke volume is the amount of blood ejected from the left ventricle per beat. Normal stroke volume is very similar to a normal heart rate, 60 to 100. Systemic vascular resistance is that parameter that tells you how hard the left ventricle has to work to perfuse your organs. What is the resistance? And when we think about vasoconstrictive states, like you might see in a shock-like state, you're going to have a very high SVR. And in states such as septic shock, early on, we're going to have a lot of vasodilation where we will actually see a decreased SVR. And the normal SVR is 800 to 1200. And how do we use all these parameters together? So the basic cardiac output, cardiac index, is your stroke volume times your heart rate. So when we think about somebody who needs to increase their cardiac output, say for instance, you're going out for a run. Your body will simply increase your cardiac output by increasing your heart rate. So if you go out for a run, your heart rate's going to go up to maybe 140, 150. Another way we can affect cardiac output is by your stroke volume, and that has several components. And when I think about stroke volume and I think about the heart as a pump, I always think you need to have three things, and those three things are your preload, afterload, and contractility. And broken down, your preload is basically your fluid status. So we can increase a patient's preload by giving them IV fluids, albumin, blood. We can decrease a patient's preload by giving them a diuretic, such as furosemide. The second component to stroke volume is afterload. And if you remember, that's how hard the left ventricle has to pump to get blood to your tissues. We increase patients' afterload all the time when we add vasopressors, such as norepinephrine and neosynephrine. We can decrease a patient's afterload by adding a vasodilator, such as nitroglycerin. And oftentimes when patients present with acute chest pain, we want to decrease their afterload, so we decrease that workload of the heart. And the third component to your heart being an effective pump with stroke volume is your contractility. And that is the strength or the force of your muscle contraction. And we often increase contractility by adding an inotrope to our patients, such as dobutamine. And that is how these components, preload, afterload, contractility, and all of the numbers and parameters that I mentioned before kind of tie together into the big picture. How do we know if we're optimizing oxygen delivery? How do we know if we're perfusing the fingers and the toes? And I mentioned before, an adequate blood pressure, a MAP of 65 or greater, does not always mean adequate blood flow to the tissues. And if you look over to the right-hand side of my slide, you'll see this is one of my favorite graphs that I've actually come across. And it shows a patient who is actively bleeding. They're bleeding maybe into their abdomen, maybe into their groin, retroperitoneal bleed, perhaps a bleed that we can't even see. And as they lose blood volume, I want you to look at the map. With this particular patients, you'll notice they can lose up to 20% of their blood volume before the mean arterial pressure starts to drop. And that just kind of highlights that looking at the map alone does not tell us the whole story. You'll notice as the patient starts to lose blood, almost immediately, their cardiac output starts to drop. And that makes sense because that's the amount of blood the heart is pumping over a minute's time. You'll also notice as the patient is starting to lose blood, their systemic vascular resistance goes up drastically. And that makes sense because the patient is vasoconstricting. So if we're just looking at the map, we are not getting the whole story here. And we're not seeing what's happening behind the scenes if we're not looking at cardiac output, cardiac index, SVR, and stroke volume. And these particular patients, I always like to visualize, these are the patients that are standing on the edge of a cliff. And they're holding on to that mean arterial pressure as best they can, but they're compensating behind the scenes and they're about to fall off the cliff. And if we can intervene before these patients take the dive off the cliff, then that's actually a very good thing. So I want to highlight 3 patients that I actually have taken care of over the course of the past couple years in a variety of ICUs. When you look at these 3 patients, you notice a very normal blood pressure. That MAP is exactly 65, and they all have relatively normal heart rates. They're slightly tachycardic, but if this patient presented in ED triage or maybe on a rapid response call, or you're at the bedside in the ICU and you see these vital signs, I'm not terribly alarmed with looking at this. But these 3 particular patients happen to have an arterial line, and I was able to use a minimally invasive device, the flow track, to get a look at those behind the scene hemodynamic parameters. And this is going to tell a very different story. So let's take a look at patient number 1. While they are maintaining a mean arterial pressure of 65, and they have a relatively, like I said, slightly tachycardic, their cardiac index is 1.9. So that's a little bit low. Their stroke volume, normal stroke volume, is 60 to 100. That is also low. And their SVR is 620. And that's telling me the patient is a little bit vasodilated. So there is something happening with this patient behind the scenes that I would not be able to see if I wasn't using the arterial line flow track device. Patient number 2, you will notice once again a mean arterial pressure of 65, but look at that cardiac index. It's 1.2. That is significantly low, and I have a lot of concerns. What is also very concerning was an SVR of 2,130. This was a patient that I actually picked up at 7 p.m. a couple years ago, and I'll go into the story in just a moment. Patient number 3, cardiac index, stroke volume, and SVR are all completely normal. So once again, all 3 of these patients have a normal mean arterial pressure, and they are each slightly tachycardic. Patient number 1 was a patient I actually cared for in the medical ICU where I currently work. They were a sepsis patient who had received some fluids down in the ER, but obviously was not adequately resuscitated. So we were able to intervene quickly and early before their blood pressure dropped. Patient number 2 was a 25-year-old who was an ATV accident. He suffered a blunt force abdominal trauma and was actually in the surgical ICU for a couple days, and they were thinking about transferring him out. They were talking about taking out his arterial line. And immediately when I looked at those numbers, the cardiac index and the SVR, I was able to get the surgical resident. We did a quick ultrasound of the abdomen, went to CAT scan, and he was class 1 to the OR. He had lost about 2.5 liters of blood into his abdomen. But remember, this patient, he was 25, he was young, he had a very healthy heart. He was vasoconstricting and doing a lot of things to maintain his mean arterial pressure. And if I didn't have access to those additional hemodynamic parameters, I most definitely think he would have fallen off the cliff, as I like to say. So we were able to get him to the OR quickly. Patient number 3 was a patient I took care of in a neurocritical care unit who was status post aneurysm clipping. He had a headache, and I gave him some Tylenol. That's why he was a little tachycardic, and he did just fine. But I highlight these 3 patients because they all had the same heart rate and mean arterial pressure, but what I was able to get with those additional hemodynamic parameters really helped me to guide in their care and to intervene early. So after my stories and my little discussion on hemodynamics, I really want us to stop focusing on the mean arterial pressure as much and to start thinking about how well is this patient perfusing? What is their blood flow? How are they perfusing their fingers, their toes, their kidneys, their liver, all the vital organs? So how do I get these fabulous numbers that I'm talking about? Well, for those of you that have been practicing in critical care as long as I have, you'll remember the PA catheters. When I started in the early 1990s, most of my ICU patients did have pulmonary artery catheters, and they're great. You get a lot of information about the right and left side of the heart. They are very invasive though, and they land, the catheter goes through the right side of your heart and lays in the pulmonary artery. You have a large central line, and they have a lot of complications. You certainly cannot thread PA catheters down in the emergency room or on rapid response calls. So we can move to another way to get these numbers, and that's the minimally invasive arterial line. And that's what I was using with patient number 1, 2, and 3. They actually had an arterial line, and I was able to use the EV1000 or the flow track to obtain these numbers. And lastly, there is a way, it's completely non-invasive. You can get the exact same numbers, SVR, stroke volume, cardiac output, and cardiac index with the ClearSight device, and that's actually a finger cuff. My hospital currently has it mounted on our rapid response cards, and I'm able to take it to RRT calls. You can use it really in any setting that you're in. The why. I do like to throw this slide up. It's just a handful of articles that I've read over the years, but it talks about using stroke volume to guide fluid resuscitation and why we should be doing this. And I'm certainly willing to provide this slide to you if you would like to see more of my references. So I want you to think about how we are treating hypotension, both in and outside of the ICU setting. Think back to the last patient that maybe you took care of that became hypotensive. Let's say their blood pressure dropped to 70/50 or 80/40. How did you treat that hypotension? And I think most of us would say that we started to give fluids, especially if you're in a surgical ICU or you're in the ED setting, or even on rapid response. A lot of times we start giving fluids, and that's great. If you're using a smart pump like I am, you're probably running a bolus of normal saline or lactated ringers at 999. So if you're giving a 500 ml fluid bolus, it's going to take 30 minutes. If you're giving a liter, it's going to take an hour. And what are we using to determine if fluid is an effective treatment for hypotension? Well, we're looking at the blood pressure. We already discussed that the blood pressure can be somewhat of a late indicator sometimes, and sometimes these patients are doing a lot behind the scenes. So how do we know while we're giving fluid if this is in fact the right treatment for the patient? And the other question I have to you is, how much fluid are you going to give before maybe you start to think about adding a vasopressor such as norepinephrine? Are you going to give a liter of fluid? Are you going to give 2 liters of fluid? And if the patient has remained hypotensive for that entire time, it might have been an hour and a half that you've allowed this patient to have a low blood pressure. And we know that low blood pressure or hypotension certainly leads to a lot of complications such as acute kidney injury. And if you're out on the floor and you're thinking about calling a rapid response, at what point do you call that rapid response? And do we ever think of adding an inotrope to these patients? Those are just some things that I wanted you to think about. And when I think about my rapid response calls and treating hypotension in the ICU, I think about how I did it maybe 10 or 15 years ago. And I like to think of an analogy of throwing a dart on the board, but I'm closing my eyes and I have a blindfold and I'm throwing that dart, and the first thing I throw at the board is fluids, and I'm hoping I get it right, but maybe I don't. And then maybe I'm going to throw something else up there, some norepinephrine. And a lot of times it depended on the provider that I had on call. Some of the providers I worked with like to give 1 or 2 liters before they went to norepinephrine. Other providers like to go right to norepinephrine with an unstable patient. And remember, when we add norepinephrine or another kind of vasopressor to our patients, it often involves adding a central line, transferring them to the ICU. So there's a lot of things in play, especially when you start to think about bed flow and where these patients land. So what I want to talk about now is there's a better way to do this. There's a better way to determine how to treat your hypotensive patients. And we do that by initially doing fluid challenges. And the way that this works is, I'm going to use an example of rapid response. If I have a patient who is dropping their blood pressure, the first thing I want to do is obtain a baseline stroke volume. And I will obtain that baseline stroke volume using either the non-invasive or the minimally invasive device. And then I'm going to give a 250 fluid challenge. And I give the fluid challenge, you have to give it rapidly. You can either give it via a pressure bag if you have access to that. If not, I'll often use 2 smart pumps at the same time, and I'll run them at 999. So that delivers that 250 milliliters over 7.5 minutes. So I obtain my stroke volume before the fluid challenge, and then I obtain my stroke volume at the end of the fluid challenge. And I compare those 2 numbers. If the stroke volume went up by 10% or more, that tells me that my patient is fluid responsive. Because remember, as you increase your preload, meaning you adding fluid, your left ventricular stroke volume will start to increase until it reaches his optimal preload. So if you look at the slide to the left, that's your Frank-Starling curve, which is something we all learned about in our pathophysiology class. And patients are fluid responsive when they are on that ascending part of the curve. And ideally, for most of our patients, we like them to be at the point where They are euvolemic, and they're at that top part of the curve. That's what we like for most of our patients. We don't want them to be too dry, and we certainly don't want them to have too much fluid. So that's how you use stroke volume in a fluid challenge to determine if your patient is fluid responsive. If you're perhaps afraid to give a fluid challenge, we do have patient populations, let's say with heart failure. Maybe they have an ejection fraction of 10% or less. Perhaps your patient is end-stage renal disease and they just came back from dialysis where they pulled maybe 2 liters off. We're a little bit hesitant to give these patients fluid, but we can still determine whether they're fluid responsive and where they are on that Frank-Starling curve by doing a passive leg raise. And this is very simple. If you'll notice in the slide, you'll have the patient sitting up in the bed at a 45-degree angle. You obtain the stroke volume. You lay their head down, you lift their legs up and hold it for 90 seconds at that 45-degree angle. At the end of the passive leg raise, you obtain their second stroke volume, and you compare the 2 numbers. And if the stroke volume has gone up by 10% or more, you know the patient is fluid responsive. Because basically what you're doing with the passive leg raise is you're giving a 250 fluid bolus of that venous blood, that venous return. So this is certainly not a therapeutic intervention, but at least it lets you know where your patient lays on that Frank-Starling curve. And for some patients, we want them to be on the lower end of the curve, maybe our heart failure patients. But I have found this to be very helpful in treating those patients because sometimes we do need to give them a fluid bolus, or perhaps you want to hold that dose of Lasix that they're due for in a couple hours. So it certainly has provided valuable information for me. What I want to talk about now is I have 2 case scenarios that I'm going to show you how I put it into practice, into my practice, using stroke volume and these advanced hemodynamic parameters. The first scenario is one of my rapid response calls. This particular patient was admitted from the emergency department. They were admitted with sepsis. I believe it was urosepsis. Down in the emergency department, they identified sepsis early. They did a great job. They got the blood cultures, gave the correct amount of fluid that we all know, the 30 milliliters per kilogram. They also checked the lactate. I believe the starting lactate was 4.5. They cleared it down to like a 2.2. Patient started to have great urine output, and their blood pressure was stable, 110/68. So this particular patient went to a step-down unit in my hospital. And they probably were up there, I want to say about 15, 20 minutes when the nurse paged an RRT. She went in to get the vital signs. The blood pressure all of a sudden is 78/50. So for those of you that are on rapid response teams, I imagine you have been to this call as well. So I immediately went to the floor, got a quick bedside report from the nurse caring for the patient. I knew the patient was septic from the diagnosis. The blood pressure was low. I immediately wanted to give a fluid challenge because we do know that our septic patients, sometimes that 30 ml per kilogram is not enough. I started by using the non-invasive finger cuff, and I obtained a stroke volume. It was 48. I gave a 250 ml fluid bolus over 7.5 minutes. I had 2 smart pumps running, and I obtained the stroke volume at the end of the fluid challenge, and it was 56. So what does that tell me? It went up by more than 10%, more like 15 or 17%. So that tells me that patient is on the ascending part of the Frank-Starling curve. They are fluid responsive. And from what we know about septic patients, I know that sometimes we need to give them, obviously, a lot of fluid. So the blood pressure still remained low. I knew the patient was fluid responsive. I went ahead and gave an additional 250 ml fluid boluses for a total of 500. And I obtained the stroke volume before and after. At the end of my second fluid bolus, the patient's stroke volume remained the same. I think it went from like 60 to 61 maybe. So that told me that my patient was now at the top part of the Frank-Starling curve. They were euvolemic. I was right where I wanted them to be. And now I'm looking at my other vital signs because I'm not ignoring blood pressure. I'm just adding additional parameters with it. At this point in time, my patient's blood pressure returned back to normal. I was also using an iStat device, and I was getting lactates, and the lactate actually went down to 1.9. And during this call, the patient had to use the bedpan. So I know that the urine output had increased as well. So based on all of these things, we decided to leave the patient on the floor. And when we wrap up our rapid response calls in my hospital, we have a huddle, and it involves myself, the provider, the resident involved in the call, and the floor, the nurse, the bedside nurse, and the charge nurse. And what we talk about is what we did on the call and the path forward and who's going to be responsible for following up. And the nurses on the floor on the sit-down unit actually had an excellent question. They asked me, they said, how do we know this blood pressure isn't going to drop 15 or 20 minutes after you leave? And I thought it was an excellent question. They were a little concerned and thought maybe the patient should go to the ICU. So I explained what I did during the call, and I explained how I used stroke volume to guide my fluid resuscitation. And I actually drew a little picture of the Frank-Starling curve, and I explained based on everything that I had done and the information that was in front of me that I felt pretty confident that this patient was going to remain stable. And I ended up following up a couple days later. They were discharged 2 days later. And I think about this call maybe 15 years ago or 10 years ago when I was a rapid response nurse. And I might have started norepinephrine after 500 mLs. I might have started it right off the bat and taken the patient to the ICU. So that is why I like to use stroke volume to guide fluid resuscitation and hypotension, because it allows me to make the right decision and it allows me to do it quickly. So my second patient that I'm going to discuss actually is a COVID-19 patient. So I mentioned that I work in a medical ICU, and during the height of the COVID crisis, so to speak, or pandemic here on the East Coast, my entire ICU was COVID positive patients. And this particular patient, I believe I treated at the end of March or beginning of April. And this was when we were following the practice of kind of intubating these patients early and sedating them. And this particular patient is a 55-year-old male. He was diagnosed with COVID-19. He at that point was intubated and sedated when I picked him up at 7 p.m. We had a RASS goal of -1. And early on, we did sedate these patients a little bit more than we normally had because we were not able to run into the room quickly because of the PPE we needed to require. So we wanted to keep these patients while they were acutely ill, somewhat sedated. And these are the vent settings the patient was on. We did go up on the PEEP up to 12 to bring the FiO2 down. We were able to get it down to 60%. And then all of a sudden my alarm is ringing because his blood pressure is 88/52 and his MAP is 60. So the thing about the COVID patients, and for those of you that cared for them in the ICU, these were not like our septic patients or our patients with ARDS. We didn't have years of practice and years of evidence-based literature to help guide our care. We really had to look at the patient that was in front of us and try to decide what was the best thing to do for that patient. We had a little bit of information from Italy, from the physicians in Italy and in Spain, but really we had to gather all the information. And I think initially I was having a discussion with the provider about the hypotension. We weren't sure, should we be giving these patients fluid like we do in sepsis? What was the right ventricle looking like? Was there an increased afterload as it was trying to perfuse the lungs? And what about the sedation? Was it possible that we had over-sedated this patient and that's why they're hypotensive? And the other thing that I actually didn't put in my slide is we talked a lot about our ARDS patients. Should we be treating them like that with low tidal volumes, higher rates, and trying to keep them dry? And the big decision in front of me was, should I give this patient fluid or should I consider immediately going to a vasopressor? This particular patient had an arterial line, and I was able to hook up the FlowTrack device, and I found out that my stroke volume was 52, which was a little bit low. My cardiac index was good. I was happy with 2.5, and my systemic vascular resistance was low normal, a little bit low, 730. So after a discussion with the team, we decided we wanted to give a 250 fluid bolus just to see if they were fluid responsive. We wanted to know where they were on the Frank-Starling curve. This particular patient, I obtained the stroke volume and it was 52. I gave the fluid bolus using a pressure bag, and the stroke volume after the fluid bolus was 61. So what does that tell me, or told me? That my patient was fluid responsive. Their stroke volume went up by more than 10%. So that told me they were on that ascending part of the Frank-Starling curve, and they weren't quite euvolemic. My blood pressure after that was a little bit better, but I still wasn't happy. So after a discussion with the team, we decided to go ahead and give another 250. And like I said, we were a little conservative with the fluids because we weren't really sure if these patients were going to respond to fluid. As I said, we didn't have all of the information like we do with our septic patients and our patients in ARDS. So after the second fluid bolus of 250, my stroke volume did not go up by 10% or more. It started at 61 and it went to 63. So that told me my patient no longer needed fluid. They were euvolemic. I was right where I wanted them to be with that. My blood pressure was still low at that point, so we decided to go ahead and start norepinephrine at 5 mics per minute. And I highlight this COVID patient because with all of our COVID patients, this was new territory for us and new ground. And these patients were very sick, the ones we had, as I'm sure yours were as well. And I wanted all of the information I could get. And part of that information for me was the hemodynamic parameters. And we were able to utilize that to guide care with these patients. This is kind of my wrap-up slide. I like to mention this because no monitoring device, just because if you hook up one of these devices, it's not going to improve a patient's outcome. You need to take the information you get from this device and couple it to a treatment that then improves the patient outcome. So take these numbers and make the informed decision that you can.